this, 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 and this. So we're going to talk about how we're going to use medicine to affect your blood pressure by not letting angiotensin 1 become angiotensin 2, or we're going to block the receptor that angiotensin 2 would bind to cause vasoconstriction. With that said, I've kept brain, antidiuretic hormone. So to diurese means to remove water that you don't need, whether you like it or not. Okay? So you're going to hear people take diuretics. You're going to hear people say they take a water pill. What they're telling you is they take a pill that makes them pee. So if I have an antidiuretic hormone, what is that hormone going to make not happen? You're not going to pee.
No pee-pee.
So if I've increased your volume by making aldosterone hold on to sodium, and I won't let you pee, what happens to your volume?
Stays high.
It goes up. What happens to your blood pressure?
Goes up.
Cool. Everybody cool? Now, that right there is the renin-angiotensin aldosterone system, but I'm going to take it one step further. So you're in shock.
Yeah. Look at this.
Your adrenal medulla is going to release norepinephrine. What's going to happen to my heart rate?
Go up.
What's going to happen to my arteries?
Constrict.
What's going to happen to my blood pressure? Oh, that's kind of cool.
Now you're dead.
Make sense? And then last but not least, so once again, we're talking about shock, so I shoot you, something like that. Your spleen holds about 200 milliliters of what's called free blood. So it's blood that's waiting to get put into the vascular system. It's probably got some immature red blood cells in it, but it's capable. So what would happen if I had my spleen squeeze that blood out?
More
What would happen to my volume? It would go up. What would happen to my blood pressure? Now do you understand compensated shock? There it is. That's compensated shock. Cool? So what's decompensated shock? So let's look at this real quick. Blood pressure goes up, heart rate goes up, respiratory rate, we said that's compensated, yes? So what's decompensated? Blood pressure does what?
Drops.
Starts to go down. Well, what happens when my blood pressure goes down?
Your heart rate.
My heart rate goes up even more because once again this is a cyclical thing. What happens to my respiratory system? It goes up. So there's my decompensated shock because what's failing? No. This isn't infinite. Right? There is only so much renin and there is only so much angiotensin, and when we can't make it, what happens?
Death.
You start to vasodilate. So what's irreversible shock?
Heart rate goes down. Everything goes down.
So what's happened over there? Complete failure. Does that make sense?
Yes.
Aldosterone.
Adrenal cortex.
Aldosterone. Adrenal cortex makes aldosterone. Aldosterone loves sodium. What does that mean? If it loves sodium, it means it's not going to let sodium be released. If I keep sodium, what else am I keeping?
Water.
Water. If I keep water, what happens to my volume? What happens to my blood volume?
Goes up.
If I increase my blood volume while I'm squeezing the hell out of your arteries, what happens to your blood pressure?
It's sky high. Death.
Everybody cool with that? Now, once again, we're talking about this in the context of shock. Next week, we're going to talk about this in ACE.
Converts to angiotensin.
There you go.
Gotcha.
Angiotensin 2 is a potent vaso.
Constrictor.
Constrictor. So this whole thing is to increase my blood pressure. Blood pressure goes up.
Where's the renin?
Kidneys. Renin, kidney. So kidney makes renin. And jump into this.
He's decompensating.
Ah, because something's going on that's keeping his heart rate high. If he was relaxing, that should go down. So once again, I can validate everything by adrenaline. But now I can't. So why is there still adrenaline going? Why is that fight or flight thing still happening? Make sense? This is the subtlety of, as Juan said, losing your license versus not losing your license. It's very easy to get into the very bad habits of watching people who think they have done this a long time go, it's all bullshit. Every call is bullshit. It's amazing. Y'all are the most psychic people that can't win Powerball that I've ever met. I've seen people stand in a bay and call go out and go, it's bullshit.
Yeah,
It's amazing.
he's right.
It's amazing.
He's right.
So use that psychic ability and
Yes,
earn me some Powerball money. All right, so let's talk about the RAS system. Brain, lungs, heart, liver, spleen. Ah, two perfectly groomed keys. Cool? So this is called the renin-angiotensin-aldosterone system, and you need to know it. Right now I'm going to show you why it keeps you alive, and next semester I'm going to show you how it's going to kill you. Okay? So, your kidneys balance water. That's their first job. Yes, they get rid of waste, but their first job is to balance water. So when you have too much, what does it do? It gets rid of it. When you have not enough, it keeps it. Okay? Now, your kidneys only understand this through a process of measuring sodium. Have you ever heard the phrase, water follows sodium? Where sodium goes, water goes. So when the sodium level goes down in your kidneys think that you are in trouble. And we must start saving you. So what the kidneys are going to do is create something called renin. Kidneys create renin. Liver creates angiotensinogen. Kidney, renin. Liver, angiotensinogen. When these two meet up, they create something called angiotensin 1. Angiotensin 1 does absolutely nothing. But it goes to the lungs. And there it finds something called angiotensin converting enzyme. We call it ACE. Next week, we're going to talk about ACE inhibitors. Go for it. What's your name?
I didn't get the last one.
You said,
This part right here?
yeah.
Angiotensin converting enzyme.
Where's
So
it coming?
angiotensin 1 goes to the lungs where it finds angiotensin converting enzyme.
Okay.
Angiotensin converting enzyme is going to take 1 and turn it into angiotensin 2. Angiotensin 2 is a potent vasoconstrictor. So what is your body trying to do? If this is telling all of your arteries to squeeze, what is your body trying to do? Raise your blood pressure. That's a good way to save you, isn't it? To raise your blood pressure.
If you need it.
You need it. Everybody cool so far?
Renin and the first angio makes Angel 1. That goes to the lungs and makes Ace.
Ace lives here.
Okay.
What you need? You've got to understand this because I'm telling you. So in 10 minutes, I'll give you 10 minutes. I realize your steak's sitting on the plate.
Losing a license is worse than a state. Cold state.
Adamant, doesn't want to go. Not hurt. Pressure go up, and my respiratory is going to go up because my bronchioles dilated. You've been in, maybe in an accident? That's a stressful environment, right? So how do I know that he's not, and don't tell him why you know. Why do you think he's thinking compensated shock?
Is the mechanism?
The mechanism's there, but he's fine.
Heart rate is over 100.
Okay, cool. I can tell you right now that if I pulled a gun and put it right in your face, your heart rate would probably be right. He doesn't hurt. He doesn't feel any pain. He is good to go. Leave him alone. He wants nothing to do with you. Are you cutting him loose?
No.
Why not?
Why not?
Ah, well, here's a question. Can I explain every bit of those vitals? You can't explain them? I can explain them. You're in an accident. Adrenaline. Compensated shock. There is decompensated. And there is irreversible. Yes? You got taught that, right?
Mm-hmm.
Did they explain what they mean by those things and how it happened? No, they didn't. I guarantee they didn't. Not, at least not in EMT school. So they just said that in compensated shock, blood pressure is going to do what?
Go
It's
up.
going to go up. My heart rate's going to do what?
Go up.
It's going to go up. And my respiratory rate's going to go
Drop.
Drop.
up. So in compensated shock, so I'm going to give you a quick little scenario and see how well you think like medics. Without having some background information, at least what you know from EMT. So you and your partner ride in a truck, right? You're in your rescue. You're going back to station. There is steaks sitting there waiting for you.
Steak fry.
Okay? Everybody cool with that?
Oh yeah.
Right in front of you, there's a decent accident. Just bang. Okay? Yeah. So you're screwed. You gotta get out. You just watched your steak go down the road. So you get out, and significant damage, and your patient gets out, and they say they're fine. They're very adamant that they're fine. Are you okay with that?
Can they answer my question?
They say hi, and yes, and nothing hurts, and they're good. Are you gonna do anything?
Can we take a
You can.
Yes, let's take a BP.
Slightly elevated.
Who's taking an EKG on this patient?
BP and pulse ox. For now.
I would be happy if you just talked to him.
BP and pulse ox.
There you go.
It's a little high.
A little.
It's expected from that.
But yeah.
Here's my question to you. He is adamant.
Can't tell me that I didn't give you something cool going on besides this stuff. It's a theory, all right.
Once again, when we get to P2 and we start talking about 12 lead EKGs, we can see on a 12 lead EKG if a patient is taking digoxin because it causes the impulse to do some weird things and it shows up on an EKG. Everybody cool with that? All right, last but not least, and then I need, we may get out close to being on time. Magnesium. Magnesium sulfate. This drug is going to pop up in 3 different categories. Today, it's going to be in the cardiac. And what happens is in this process right here, so that sodium potassium pump, ATPase, I also need magnesium to make the membrane of the cell more acceptable. So the problem is if you don't have a whole lot of magnesium, you can go into something called torsades de pointes. Okay? We'll talk all about this next semester. There's 2 reasons that we will call something torsades de pointe. One is hypomagnesemia. Why would I think my patient's hypomagnesemic? Why would they have lost a lot of magnesium?
Dehydration.
Cause from?
Sweating.
Alcoholics have a tendency to be hypomagnesemic. So once again, if I show up and see a specific rhythm, and I've got a history of alcoholism, I may think this is torsades. Okay. You're also going to see magnesium in the respiratory. So next week we're going to talk about magnesium again. It is a smooth
Muscle relaxer.
muscle relaxer. Your bronchioles are made from smooth muscles. So we will use magnesium when albuterol, Atrovent, and the anti-inflammatory aren't getting me where I want to go. Huh? Yep. So when we're also going to see it in P3. So we're going to see it in preeclampsia, where there's hypertension in pregnancy, and you're also going to see it as a way to stop preterm labor. Now, unless you do intrafacility work, meaning you're taking a patient from point A to point B, hospital to hospital, something like that, and you have a preterm patient, a preterm labor patient going to a higher skilled OB facility, and they're on a mag drip, you will never see mag used in the field for that. We don't stop preterm labor locally. But just realize it does that. So magnesium is an electrolyte. It works in the cardiac system, it works in the respiratory system, and it works in the OB or the gynecology system. Everybody cool? Didn't mess with your brain too bad. And allows the AV node to reset itself, taking a very fast rhythm and recycling it back to its underlying rhythm from the SA node. Everybody cool? All right. Maybe we'll talk about that next. Digoxin. So I'm just going to kind of give you a quickie on this one. Back in intro, I showed you a picture of a plant. And we called it the purple foxglove, and we said it was a very poisonous plant. And I said, but it's also a medication. In this case, it's digoxin. So digoxin, Lunoxin, or digitalis, they're all the same drug. Why the National Registry wants you to know this, I have no clue. We do not, and probably never will, administer digoxin because its therapeutic index is measured in micrograms. What does that mean? Very, very small, right? So we can go from okay to overdosed like that, okay? The reason that people are on Lunoxin, digoxin, or digitalis is because they have heart failure. And digitalis makes the heart squeeze harder. So you will see patients who will tell you, I had a heart attack, I've got an ejection fraction of 50%, I've lost 30% of my ventricle, and they are on that medicine. They are on it to make the other part of the ventricle that still works squeeze harder to keep their blood pressure up. All right, so here's your general education mixed in with paramedic school. Everybody know Van Gogh? Mm-hmm. Cool. Van Gogh had a period, they call it the blue period. So there's a very famous painting called Starry Night. There's a lot of paintings from the blue period. So it's blue background with yellow stars that have halos around it. Guess what the side effect of being dig toxic is? Seeing halos around lights. So they think that he was dig toxic while he was in that period because what he was seeing were lights that had halos around it, and that's what he painted. Medical directors are going to be here in your face throughout the semesters. Next semester is all cardiology. That's what the doctors are going to be here for. When you get an SVT patient and you don't put the pads on them, the ass chewing that you will get is yours and yours alone. Too many people love to go adenosine save loop through the AV node. It's blocking any impulse that's coming this way. I'm just creating this loop. Every time it goes by, it goes down. And now I have a rate greater than 150 beats a minute. Narrow complex because it's following the pathway correctly, but now we're doing this at 150 plus beats a minute. So we're going to give adenosine. Adenosine, so it increases potassium efflux, so potassium is going to leave. And it's going to inhibit calcium influx, so we're going to tell calcium not to. And what we're going to do is we're going to hyperpolarize the AV node. I'm literally going to put it in a state of massive positivity. It really thinks highly of itself. Right? Does everybody understand what I mean by that? Which means that it cannot do anything. So eventually what's going to happen to this cycle? It's going to stop. Only lasts 10 seconds. So in 10 seconds, I reestablish my AV node. My SA node was still doing its thing, so what happens? It goes right back to a good old-fashioned sinus rhythm. So how many of you heard of cardioversion? Electricity. Meet the chemical version of it. Okay, so I will tell you, all you baby medics, the first time you push adenosine, put the pads on. Class 2, beta blocker. Class 3, potassium channel blocker. Class 4, calcium channel blocker. Class 1, phase 0. Class 3, phase 3. Everybody good? Can everybody handle that? All right. Now, miscellaneous drugs. Adenosine. Y'all heard about it?
Yes.
Cool. Anybody know anything about it?
That was heart rate.
So what?
Slows down the heart.
It does. One specific rhythm. SVT. Okay? It has a half-life of 10 seconds. So this is not one of those drugs where you go, yeah, I think I'm going to try adenosine. So once again, listen carefully. When you use adenosine, you need to start an IV as close to the heart as possible. So technically, where would that be? EJ. The answer to that is no. We do not start EJs on patients who are sitting up talking to us who are good, who have ACs. Everybody clear with that? Okay. But once again, this is a thought process. So if I go, hey, get me an IV, and I go, hey, cool, and I put a 24 gauge in the top of your foot, can you give adenosine?
No.
No. By the time it gets there, most of it's going to be
Gone.
gone. So this is a thought process of when I want to use adenosine, I need an IV. Doesn't need to be an 18. Don't fall into that crap either. But I do need it in an AC. Am I cool with that? All right. So we'll come over here. SA node, AV node. So this is a drawing of the AV node. Okay. So what happens is an impulse comes down, comes into the AV node, and it goes down one side, and it goes down the other side. One side is fast, one side is slow. And eventually it gets down here, and it goes down, and what does it do to the ventricle? Yeah, it depolarizes the ventricle. So my ventricles squeeze. Does that make sense? Okay. So what happens with SVT, and I'm kind of giving you a 1,000-foot view because we will get way into this next semester. But what happens is if something depolarizes fast, it has to repolarize slow. Same concept. If it depolarizes slow, it repolarizes fast. So what would happen if my little signal's coming down 60 beats a minute? That means I got some time in between, right? What happens if this cell right here goes off? Remember automaticity, right? So could that cell go off on its own? Yeah. So while we're waiting, while we're trying to repolarize down here, I send an impulse in. AV node's not ready to go. Half of it is, but half of it isn't. So the half that is says, sure, I'll let that in. And the half that isn't says, it's going to stop right there. Well, where does it go? Comes down. By the time it goes down, we're going to come back now. Does that make sense? One's depolarizing, one's repolarizing. One's depolarizing, one's repolarizing. So what happens is I create a loop. Have you ever watched a dog chase its tail?
Yeah.
What happens? It gets back. I have heard arguments of why we use one versus the other, and I've heard arguments that are as simple as this. Easy math.
Here it is.
They all do the same thing. Easy math. Not my decision to make, that's a doctor's decision. So once again, if you have both, somewhere in your protocol it's going to say if you have this, use that, and if you have this. And it may say that you can use both if one doesn't work. If you are limited to having one or the other, that's what your doctor has chosen. What I just need you to know is that if you see a test and it says amiodarone is a class, what is it? It's a potassium, and it's going to affect
Phase 3.
The
phase 3.
Oh, phase 3 class 3.
Huh?
Phase 3 class.
Everybody cool? So, once again, as I said, we're going to use it in codes. You are going to become intimately familiar with amiodarone. You will eat, sleep, and breathe amiodarone until you are dreaming about it.
And then we code and we use it.
Maybe. It might be going away, but don't worry about that yet. There's some stuff going on with a lot of things that are changing. All right, class 4. So class 4 is a calcium channel blocker. Now, let me be very careful with what I'm about to tell you. Okay? Calcium makes muscle squeeze. So there are drugs that are calcium channel blockers that work specifically on the heart, and there are calcium channel blockers that work specifically on the arteries. So in the heart, what we're going to do is we're going to decrease this SA node firing capability. So remember, go back to this. How did we turn this on? What was the electrolyte? How did I turn a conduction cell on?
influx of
An influx of calcium. How did I turn it off? An efflux of potassium. So realize that if I give you a calcium channel blocker, would I be affecting your conduction pathway? Would I be speeding it up or slowing it down? Slowing it down. So what's your heart rate going to do? Slow down. Everybody cool with that? Now, we will talk next week about calcium channel blockers that work on the artery. So your artery has 3 layers. The middle layer is a muscle. And when your artery needs to get smaller, what does your muscle do? Constricts. How does it constrict? Calcium. So realize that if I want your artery to not constrict, I would give you a calcium channel blocker. They work on 2 different things. Is everybody clear with that? Right now, you need to know the word diltiazem. The other name for that is cardizem, which I'm sure all of you have heard. It is used for AFib. Okay? Now, notice big capital letters, so I'm screaming at you. Yes? Okay. Etiquette of texting. Diltiazem only works above the ventricle. So it works on the SA node and it works on the AV node, slowing the conduction down. So turning it on slower than normal. It does not convert rhythms. So this is what I'm going to tell you throughout the next year of your existence here. People are going to tell you things, and they are full of shit. But they're going to tell you very convincingly because they heard it somewhere. Okay? AFib does not convert with cardizem or diltiazem. What I want to do is slow the rate down. Now, could the rate convert back, or could the rhythm convert back? Yes. Take the pressure off the atrium, goes back into a sinus rhythm. The diltiazem did not directly do that. Everybody cool with that? Yes, yes? Okay. So I'm going to point things out that you will hear. How many of you have ever heard that, anybody have DKA? Yes? Mm-hmm. Sugars through the roof. You know what we give them? Fluid. Why? Huh? How do I don't flush the sugar out. So what's going to happen to my repolarization? Is it going to speed up or slow down? Slow down. So it's going to take longer to get back to a reset phase. So once again, if I have a fast heart rate, what should happen? It should slow down. If I've got a weird event going on, I should stabilize that. Everybody cool with that? Okay. Seen it? Amiodarone. Okay. This is the antidysrhythmic of choice for VTAC, with and without a pulse, and VFib, and PVCs. Don't panic over knowing anything like that yet, but just realize those are all codes, except for the last part. So VTAC and VTAC with a pulse, VTAC without a pulse, and VFib can all be codes. You will use amiodarone. Now, just because we have to teach you medicine, and medicine has to be a pain in the ass, amiodarone is a weird little dude. Amiodarone is classified as a class 3 drug. So if you are asked on any test, what is the classification, the Vaughan-Williams classification of amiodarone, your answer is 3. Here's the truth of amiodarone. It acts as a sodium channel blocker. It acts as a beta blocker. It acts as it is intended as a potassium channel blocker. And it also plays in class 4. Yes, sir.
To find out which class of drug you need, is that just from the EKG?
That's your medical director. So once again, where people tell us we're medics and you make 0 decisions. What's in your box? Lidocaine or amiodarone?
But
Cool. So you're somewhere in your protocol, your doctor says if it's this, use that. If it's this, use this. Make sense? Now, there's rationale for using one versus the other. And once again, that's doctor world. Okay? And I can tell you for a fact, I've heard a lot of arguments between this drug and that drug. So realize that when I first started, this was the drug. This was the antidysrhythmic. In about 1996 or 7, somewhere in that neighborhood, one day we woke up and they went, nope. That's it. Literally. Workload of the heart. This is how capable is your heart of perfusing while under a load. So meaning, if my heart's beating really fast, am I capable of getting enough oxygen to my heart? How will you know you're not? How will you know you're not getting enough oxygen to the heart? They will tell you they have chest pain. 1 to 1. Everybody cool with that? So, let's look at the drugs. On the left, non-selective beta blockers. So what are they blocking? Beta. Beta. Beta is beta, except for when you make one little change and make it beta 1, or one little change and make it. But 99%, both of them look like beta. So if I gave you a non-selective beta blocker, what might happen besides your heart rate going down and your blood pressure going down? Bronchoconstriction. So how would I know I have that? Wheezing. Okay. Labetalol is a very common IV beta blocker given in EMS. Cardioselective. Cardioselective to which beta? Beta 1. So if my patient takes metoprolol or atenolol or bispirol, what are they blocking? Beta 1. So I expect their heart rate to be low, and I expect their blood pressure to be lower. Everybody cool with that? What do you notice?
Law.
Generic name, generic name, generic name, generic name, generic name, generic name. Those are all generics. I walk in the door, I have never heard of Sotalol in my life, but what do I know? Ends in LOL, so it has to be a beta blocker. Now, I need to figure out is it selective or not, especially if my patient's having wheezy. But you will see this is the most prevalent prescribed beta blocker in the United States. For some reason, the National Registry EMS testing likes this drug, and they like to use that name. So, generic, trade. So anything in red, make sure you're aware of it. Everybody cool? Class 3. So now we're going to talk about potassium channel. So what phase of the myocyte do you think we're affecting?
3.
We're affecting phase 3. So we're going to take those potassium channels, block some of them, which is going to keep potassium from doing what? Okay? Okay. Class 2. Beta blockers. We already talked about those. How did we talk about them? What did we talk about them? What did we say they were? Those are sympatholytic drugs, right? So it's going to block the sympathetic nervous system, and we said that that is going to drop blood pressure. So when you go to a patient's house, you're going to see these drugs. 9 times out of 10, they're going to be on the drug for hypertension. Okay, everybody cool with that? These absolutely affect the SA node and the AV node. But now we're going to look at it in a context of maybe I need to be giving this drug for some other reason other than management of hypertension. We don't manage hypertension. But look at this. These are really fast heart rates. So you've heard AFib, yes? Okay, so AFib is where it's all over the place. When it gets really fast, we call it RVR. It just means it's greater than 150 beats a minute. Okay? So if I gave you something to slow your SA node and AV node down, what do you think would happen to that fast AFib? It might slow down for me. Everybody's heard of SVT? I'm going to show you what it is today, but realize I could do that because SVT is an AV node problem. Well, where do beta blockers work? SA node and the AV node. Now, once again, not first line medicine. We got other medicines. Hypertensive crisis. So hypertensive emergencies is you're hypertensive and I'm seeing other signs and symptoms. Your blood pressure is 200 over 100, you have chest pain. Am I going to treat your blood pressure? No, I'm going to treat your chest pain. And by treating your chest pain, guess what's going to happen to your blood pressure? It's going to go down. Does that make sense? Okay. So there are EMS agencies that carry IV beta blocker. Why would I want to give a person having a heart attack a beta blocker? Less stress on the heart. So what's a heart attack? What is a myocardial infarction? Let's use all the big words today. Okay, so it's a block in the coronary artery. So it's either a partial or a full complete block. What am I doing to the blood? What am I doing to the perfusion of the muscle tissue? Decreasing. So if I'm not getting a lot of blood to the muscle tissue, it's going to start to die. So if I make your heart beat 100 beats a minute, am I making the heart attack better or worse? Worse. So what could I give you? Give you a beta blocker and lower your heart rate. Has nothing.
I have a question.
No, you don't. One question per semester. Sodium channel blockers. Okay. These two are used for fast rhythms and wide complex tachycardias. Don't get too caught up with that yet. Unless you know your rhythms, don't worry about that. But you're going to see these when we work codes. Because these are things that are going to try to stabilize the heart. By blocking in phase
0.
Okay. What it does not do is sodium channels do not play a role here or here. If the heart rate slows down, it's because I'm keeping the depolarization rate down, not blocking the SA node. Everybody cool with that? Now, when you see this, anything in red, you better know. And I mean that because next semester, these are two drugs you have to be able to tell me about. Lidocaine and procainamide are the sodium channel blocker antidysrhythmics that you are going to be exposed to as an EMS professional. Okay? Quinidine, you're going to run a patient who has congestive heart failure, who has had a heart attack in the past. And you look at their medicine and it says quinidine. Cool. It's a sodium channel blocker. So why are they taking it? What do they probably have a tendency of? Yes. Or a dysrhythmia, meaning the rhythm does not move through correctly. You will see this drug in a couple of places. So phenytoin or Dilantin. I can almost guarantee, how many of you run a seizure patient? I can almost guarantee you've seen the word Dilantin because Dilantin is a sodium channel blocker. Here's a quick physiology lesson. All cells depolarize by sodium. So muscle cells depolarize by sodium, neurons depolarize by sodium. So if you have a tendency to have a seizure, I can put you on a sodium channel blocker and tell your neurons to not get overly excited, and you shouldn't have a seizure. Now, once again, it's a sodium channel blocker, so you will see patients who have heart issues taking this. Probably more seizures than heart. Flecainide, the only place you're going to see flecainide is when you do your ICU rotation. That is the only place you're going to see it. It is one of those nasty drugs that only doctors get to play with, and it's one of those drugs that's keeping you alive. Does that make sense? We don't play with that. These are the two we play with. Look at that name.
Lidocaine.
Cocaine. Here's concept. Cocaine is an anesthetic. It's a sodium channel blocker. So when you're buying your cocaine and you're not really sure you're your dealer, stick your finger in the cocaine, rub it on your gums, and if your gums go numb,
Good shit.
there's good shit in there.
Okay.
If your gums don't go numb, they're selling you crap.
That's good to
Okay?
know.
So think about it. Anybody been to the dentist?
Yes.
Huh? What'd you get?
Shot.
Novocaine. Yeah. Novocaine, Xylocaine.
Right before you started talking, yeah, right here.
Sodium channel blockers. So sodium channel blockers block sodium channels. So in this myocyte, we found a whole bunch of sodium channels. And we said at some point we're going to open them and let sodium flood in, right? We called that phase,
0.
and we called that we called that myocyte depolarized. So what if I blocked some of these? What if I block some of these
Slows.
channels? How much sodium is going to rush in?
Less.
Less. So what's going to happen to the depolarization rate?
We're slowing it down.
Has to slow down. So if I take that as a whole, if I did that to all of the pieces of muscle that we're talking about, what would happen to my heart rate?
Slow down.
It would settle down.
Hi, I'm Bruce. Welcome to
We are talking about anti-dysrhythmics. I will tell you this, anytime you see names, realize that these are doctors that figured this stuff out and they get to attach their name to something. So this happened to be Dr. Vaughn and Dr. Williams, and they figured out this classification for these drugs. Anybody learned Starling's Law in EMT school? Starling's Law in Structure and Function?
I remember.
Yeah, so it's Dr. Starling. He was a physicist, and he figured out that if you stretch the hell out of the myocardium, it snaps back harder and it increases your blood pressure. So anytime that you see names attached, so next semester we'll talk about MOBITs and we'll talk about a whole bunch of different things. They're just doctors that figured stuff out, and because you're smart like that, your name gets to attach to it. So Vaughan-Williams classification system is for anti-dysrhythmics. The Vaughan-Williams classification system is for anti-dysrhythmics. There are 4 classes. You need to be able to tell me what they do and where they work. Am I cool with that? Yes, yes? All right. So, class 1 anti-dysrhythmics are sodium channel blockers. So what phase of the myocyte do you think they affect?
Influx of sodium.
0.
Oh, never mind.
There's my influx of sodium. And we said that was by opening a whole bunch of sodium channels. So if I have a sodium channel blocker, what am I doing? We're blocking some of the sodium channels. Realize if I blocked every one of them, what would happen?
Nothing.
You'd die. Your heart would not respond. Okay? Everybody cool? So class 1 is sodium channel blockers. I need you to understand phase 0. This is where these work. So what we're going to do is we're going to slow that impulse from negative to positive. So what's going to happen to my fast rhythm? It's going to slow down. Make sense? I'm going to slow the depolarization of this cell. And if I slow that down, that means ultimately I have to slow the whole heart down, which means your heart rate should come down. Okay? Now, it is not affecting the SA or the AV node. Has zero to do with these two things. Has everything in the world to do with this muscle. Everybody clue? Everybody Carol? I'm out. You're done. You messed me up. You made me say it twice.
Second time, sorry.
Second time then. Yeah. This tissue depolarizes, yes?
Yes.
What's sitting next to it at some point?
Muscle.
Muscle. Right? So that's the whole concept of this, is this, one of these cells is going to start to depolarize. Yes, it's going to depolarize another conduction cell, but at some point it's enough. What would you tell me? What two
Fast potential.
cations? Calcium?
Potassium.
Potassium. If I asked you how to depolarize a myocyte, you would tell me? Sodium. And what phase is that? Zero. If I asked you to repolarize, you would tell me? Potassium out, and that would be phase? Cool. What happens in phase 2?
It's calcium.
What happens?
Calcium.
Ah, you get muscle contraction caused by
Calcium.
calcium inflecting into the cell from the reticulum. Can everybody handle that? This is 60 beats a minute. Cool? So what's happening?
Everything.
So every time this snaps, that's happening. Then that time to the next is the time for it to reset itself, right? Cool. Now I'm going to give you a patient that has SVT. And they have a heart rate of 200.
Oh my god.
Guess what? So we have changed electrically, we have squeezed, we have relaxed, and we have converted back electrically to right where we started. Did we really?
No.
What's still in here? Whole lot of sodium. What's out here?
Potassium.
Whole lot of potassium. So now I need the sodium potassium pump. What's the ratio? 3 to 2 for every ATP. So I take ATP ACE and I push 3 sodium out and I push 2 potassium back in until we have that happy, we have more potassium in and sodium out. Now I want you to understand this. 400 milliseconds. All of the positive charge, that's why we say it's relatively negative. Potassium is not negative.
It's just
Because there's just not a lot of it. It is going to grab actin and myosin. And everybody seen Velcro? Hook and loop, right? What happens when I put hook and loop together? They grab each other. So calcium takes actin and myosin and makes it grab, but then it makes it twist. So what happens when I twist a muscle cell? Muscle fiber. Huh?
It gets tighter.
Yeah, it shortens. And you call that contraction. Flexion. Does that make sense? Calcium causes muscle contraction. So we went from resting, sodium rushing in, going from negative to positive. We shut that gate off, we start to leak, and now we have calcium enter the cell as a whole. It lived in there, but now it's living with everything else. Does that make sense? So notice what happens to our repolarization. Does it kind of stop? See it plateau? So this is called the plateau phase. This is 100% muscle squeeze. Once again, at some point we're going to be leaking and we're going to reach another voltage gate that's going to close that channel. And potassium channel is going to open. So what is potassium going to do?
Wow.
It's going to leave. Why does it want to leave?
Because it wants to join the others.
Potassium is the most prevalent
Outside.
intracellular cation. It doesn't want to be there. It wants to be outside. So what happens? All of those positives are leaving. So what happens to my cell?
Repolarize.
So we depolarized and we repolarized. Yes, sir?
I have a question.
That's why you raised your hand. Graph right here. This graph represents what's happening electrically here. Everybody cool with that? This graph has 5 phases. 4, 0, 1, 2, 3. Now, how many of you watched the videos? Okay, so hopefully a little bit of this sounds familiar. If not, the rest of you, when I tell you to watch something, it's because this stuff is kind of hard to get. And at least having some information coming in is going to make it a little easier. We are not getting into the biochemistry of this. What I will tell you is all cells leak. Is that pretty cool? All cells leak. So those voltage gates are created because of leakage. Okay? So what we're going to say is that in this myocyte, I have what's called a resting potential. So we're going to call this phase 4. What does a resting potential mean? It's resting. It's not doing anything. It's waiting for the next
Opportunity.
impulse. Now, once again, this could be once every second. This could be once every 1/10 of a second. But I have a resting potential. Yes, yes? Cool. So, just for the sake of showing you, at a resting potential, you have a negative 90 millivolt internal charge. Does that make sense? Don't worry about the number. But it's negative. So what did I tell you what this cell was? Relatively negative compared to the outside world. There it is right there. So things leak. Things that are leaking are potassium. Potassium's leaking. So at some point, we're going to start climbing. We're going to start depolarizing the cell. And at some point, somewhere, this sodium channel is going to reach the voltage it likes and slam open. Sodium's going to do what? It's going to rush in. So what's going to happen to my internal electrical state? We're going to become massively positive. So it goes to about plus 10 millivolts. Okay? Now, that phase is called phase 0, and it is 100% sodium influxing into the cell. Big fancy word that means sodium's going in. So phase 0 is sodium. And we are depolarizing the cell. Everybody cool with that? So we get up here to plus 10 millivolts and we close these channels. So now I've got a whole bunch of sodium sitting up here, right? What do these cells all do? They leak. So if you notice, what are we doing? We're leaking. So we're heading back to being repolarized. Okay? We're heading back towards a negative state. At 0, sorry, this is going to be in blue. It has nothing to do with sodium. At plus or minus 0 millivolts, a calcium channel is going to open. That calcium channel lives in here. This is the sarcoplastic reticulum. Anybody remember that from biology? Sarcoplastic reticulum is full of calcium. When you get to that 0, this calcium channel is going to open, and calcium is going to flood out of the reticulum into the, is when you look at the monitor and go, my patient has a pulse of 50. No, they don't. That's the first thing I want to ask you. How do you know your patient has a pulse of 50? And you're going to point at the monitor. Do you know what my next question is going to be for you? Show me where you got the pulse on the monitor. Show me where on the monitor there's pulse. So what are you seeing on a monitor?
Electrical current.
I'm seeing an electrical discharge at a rate of 50. This process right here. We're going to open up a calcium channel, and this cell is going to get flooded with what? Calcium. And it's going to turn on. Everybody cool with that? Cool. So when this cell gets turned on, guess what's going to happen to this cell? A calcium channel is going to open, and we're going to flood it with, and we're going to turn this cell on. While this cell is turning on, this cell is turning
Off.
So what we're doing is we're allowing potassium to leave. So in order for a conduction cell to depolarize and repolarize, I need an influx of calcium and an efflux of potassium. All this cell does is turn on and off. It does nothing else. Am I clear with that? It does. Which means that I don't need my brain to tell my heart to beat. My heart can do its own thing. It needs 0 impulse or input from the rest of the body. It would like input, but it doesn't need it. So, you have your SA node. This is called the pacemaker of the heart. You have your intranodal pathways. So this right here is right here. Okay? What they don't show you, and I don't know why, is you have a branch off of that that goes from the right atrium to the left atrium called Bachman's bundle. Don't panic over that yet. But what is this whole thing designed to do? Send a signal, tell the atrium to
Squeeze.
squeeze. Cool. So here's a question. Anybody know what the Audubon is? What is it?
It's that high.
It's that highway.
That goes fast.
Does it?
Well,
Does it go fast everywhere?
There's no speed limit, right?
Yeah, there is. There is absolutely speeds on the. There are speed limits on
there's
the
certain
Audubon.
areas.
Yeah, you can. No, so there are places on the Audubon you can get in your car and go fast, and you think you're fast until somebody passes you. Okay, 200 miles an hour, no big deal. No harm, no foul. The problem is that there are places where little towns, things like that, where you have to slow down. So if you think of this as the Audubon, it's fast. Impulse travels quickly until it reaches the AV node. What's the AV node's job? To slow that impulse down, hold it for a fraction of a second, and then send it on its way. Once it gets back into this tissue, is it fast or slow?
Fast.
It's fast. Okay? Does everybody understand that?
Mm-hmm.
Cool. Now, what you need to understand is how does this tissue create electrical impulse? So automaticity is a cell's ability to discharge on its own. Doesn't need an impulse, doesn't need input from anything else. This cell can go, cool, I'm going to do something. And it does. Okay? Normally, an impulse starts in the SA node. So you have these cells, and we're going to call them conduction cells. Takes 400 milliseconds. The tricuspid valve that winds up in the right ventricle. Right ventricle through the pulmonic valve into the pulmonary artery. Where it goes to the lungs for what? Oxygen exchange. So CO2, O2 exchange. Comes back to the left atrium. It now has blood in it. Goes through the mitral or bicuspid valve into the left ventricle, and from the left ventricle it squeezes out to the body. Okay? So we're making this cell relatively more positive than its surroundings. So I have depolarized the cell. Everybody cool? The cell hasn't done anything. It hasn't moved, it hasn't changed positions. All it did was change electrical gradient. Can everybody handle that? Cool? Okay. So, cardiology is what paramedics do. You're going to get ACLS next semester. You know who teaches ACLS classes?
Bruce.
Yes, so it's doing nothing. Okay? It's just sitting there. What we say is that electrically, this cell, the inside of this cell, is relatively negative compared to its surroundings. Does everybody understand what I mean by that? If you were to take all of the cations and anions that live in this cell, and you added them all up, let's say that was 60. Cool? If I added up all of the cations and anions outside of the cell, let's say that's 180. Does that make sense? So electrically, there's less charge in here than there is outside. So we say this is relatively negative to the outside world. Does everybody understand that?
Mhm.
Yes? Cool. So what we're going to talk about a lot next semester we're going to talk about depolarizing and polarizing cells. Okay? So I need this cell to depolarize. So what I want it to do is I want it to become more electrically associated than the outside world. Is everybody cool with that? So what we're going to do is we're going to open up a door. We're going to call this a sodium channel. So guess what runs through a sodium channel?
Sodium.
Sodium. What do we know about sodium? What is sodium?
Salt.
It is. Where does it live?
Outside.
It's the most abundant extracellular cation. Ton of sodium out here. Is there sodium in here? Yeah, absolutely. There's sodium, there's potassium, there's calcium, there's magnesium, there's a whole bunch of stuff. Is there a lot of sodium in here?
Nope.
No. So where would this sodium that's out here, where would it like to be? Cool. So if I open this door, guess I should have done that in blue. Sodium's going to rush in, correct? Cool. So what's going to happen to my cell?
Gonna equal out?
I got a whole lot of space for sodium, so a whole lot of sodium is going to rush in.
Change the electricity.
Okay, so we're going to say that it changed polarity.
Yes.
So we're going to go from relatively negative to relatively
Positive.
positive. What I have done is depolarized the cell. I took it from one pole to another pole. Everybody cool with that? Yes, sir.
How do you get the door?
How do I get the door?
Yeah.
So these are, how deep do you want to get?
As much as I need to know.
Biochemistry?
Do I need to know it?
No.
Then no.
These are called electric, we don't treat high blood pressure because there's too many complications after that, right? We treat low blood pressure. So that's what that was. You're going to see that when we get to cardiology next semester, atropine is going to fall into this category also. Does that make sense? Because it does affect the heart specifically. But right now what we're going to talk about is antidysrhythmics. Okay? So a rhythm, when we say rhythm, what we're saying is, what does the heart electrically produce? So I'm sure everybody has seen one of these, yes?
Yes.
So this is a P wave, a QRS, a T wave. What that represents is the electrical conduction through the heart. And if it does it kind of in that fashion, we say that the electricity is moving normally. And there is no such thing as normal sinus, so get that out of your mouth before next semester. It's just sinus. Okay? So what is a dysrhythmia then?
Anything other than sinus?
Okay, so truth be told, if you're sitting here with a heart rate of 55, you have bradycardia. Bradycardia by definition is a dysrhythmia because a normal rhythm should be between 60 and 100. Now, am I treating it? No. But you technically have a dysrhythmia. You have a dysrhythmia because of rate. What if the electricity didn't follow the pathway correctly? Then I would have a dysrhythmia because of conduction. Does that make sense? Okay. That's what you're going to spend 6 weeks of your next semester learning. Is how to read all of those EKGs and figure out where in the conduction pathway we have a problem. So if I have a dysrhythmia, I'm going to use a medication to stop that dysrhythmia. So we're going to call these meds anti-dysrhythmias. So everything we're going to talk about is going to be associated with some form of a rhythm, and there may be rate involvement, but it's because of the rhythm. Everybody cool with that? All right, physiology before we get to pharmacology. I'm not even going to ask the question because I already know the answer. So, this is a myocyte. Everybody cool with that?
Yep.
Okay. This is the piece of muscle tissue in your heart that squeezes. Can everybody